Who's doing it? Is Amy and Liz or just Amy? Is Liz on here?
Not yet. She typically doesn't.
If I'm gonna tag people on Facebook, should I tag her too? Or is she gonna cry? Probably.
Who knows?
I don't like criers. I don't like criers. And Renee.
Hi, Dr. Phelps here.
Hi, Dr. Phillips. You have rang in right at noon, so we can go ahead and get started. Thank you all so much for joining. I know we've got a very packed call today, and so we do want to be cognizant of your time and get going. If you do not see the webinar slides, please do click on that Ready Talk webinar link that is in the meeting invitation. That will bring you to a couple login questions and things, but then you'll be able to see the slides that we'll be going through. And with that, we typically do have some folks continue to join as a couple minutes pass as folks are transitioning from appointments to lunch. And so because of that, I'll keep attendance here. If you don't see your name on the webinar, or have troubles with it, do let me know that you're attending, because this is how I'll keep track of who's on the call. I first wanted to take a moment, one, to thank you all so much for joining, and secondly, to thank our presenters. We have a great group of presenters today that serve as partners and some fantastic resources for Ohioans. And we've got the Children's Hunger Alliance, the Ohio Department of Job and Family Services, the Boys and Girls Club of Central Ohio, and 2 offices within the Ohio Department of Health. We have WIC and the Home Visitors Programs. So each of these offer some resources across the state or regionally, and really thinking that it would be helpful for all of you to be more familiar with these programs and have an opportunity to ask questions. And so just a quick rundown of how today's call will proceed. We're doing the welcome right now. We'll move through with our KEDA data and questions section that we've done in previous webinars by Dr. Samantha Anzolk, our KEDA consultant. And then we will move forward with a panel discussion from each of our presenters, and we'll have some additional time for questions and questions for our panelists or concerns you have for me with KEDA. And you are also welcome if you have a very brief question to ask during the panel, but otherwise we ask that you reserve those toward the end. And with that, I will pass it over to Dr. Anzolk to present on KEDA.
Good afternoon, everyone. So I'm going to advance to our KEDA diagram, and just like on the past hot topic calls, reiterating what we're trying to accomplish over the course of this quality improvement project framework.
So I can tag them.
Timeline to accomplish roles.
Great job. Use a landline. Should we tell her?
Hey, Sam. Samantha. Your phone is cutting in and out. Would you mind starting that over? And just FYI for folks on the call, I will begin recording the call. And so this will be for those folks who are unable to make it today. We'll send this around so they can catch up.
Conference recording started.
All right, can you hear me better now?
That is much better, thank you.
Okay. All right, so just like on the past hot topic calls, starting with the key driver diagram and the different aims that we're trying to accomplish during the course of this quality improvement project, and then how that can improve the components of your well child visits, birth through 5 years of age, looking specifically at a comprehensive documentation of obesity-related health risk, how you're approaching anticipatory guidance on diet and activity, and then when it's applicable to families if you identify any red flags or risks, using your motivational interviewing skills to set goals when appropriate, and then to follow up on any goals that may have been set at a previous well visit encounter. And with this hot topic call and then a previous one, there's been some really good improvements that have been made in the majority of the measures. And I've put 2 placeholder slides here just so anyone can chime in and say, you know, what really worked for you to help move the needle on some of these measures. I'm not looking really at cycle 7 since that's just one provider's worth of data, but really looking at all the baseline cycles 1 and 2, and then the improvement period cycles of 3 through 6. A good chunk of these measures have continually improved and have met and or exceeded the goals that we've set. So the first ones are looking at growth and weight status. This one we still have a little bit of area for improvement to have occur by the end of this quality improvement project, but we're hovering, we've been within the 70s and now we're just shy of 70% of the time documenting weight status of the child. Looking at growth trajectory, however, we've seen a nice steady improvement from cycle 3 all the way through 6, where we're just shy of our 95% goal, with 92% of the time you're documenting those growth trajectory discussions with your family. And then the blood pressure and family history, again, not looking at cycle 7 just because it is one provider and it's a smaller sample size, particularly in this blood pressure measure. But 55% of the time, or 52% of the time, we're documenting the blood pressure and blood pressure category of that child. And then looking at family history and initial collection or update, having that obesity-centric review, or noting whether or not the history was available for any of those foster or adopted children. 75% of the time now, we're looking at appropriate documentation with this measure. With blood pressure, though, I wanted to kind of pose to the group what's really working for you as you're documenting these components for 3 years and older, and maybe what are some barriers to this so we can have some discussion and see what may be helpful, what's a hindrance, and how we can help move the needle a little further on this measure since it's lacking. And you can feel free to chime in, or you can put some in the chat box and we can read those out. Anyway, to just kind of let us know how things are going for you.
How are folks doing with the chart review component where we've added that part where now you can mark if there is a child under 3 where you wouldn't do a blood pressure reading? Has that been helpful to you? Has that been more clear? How's that working?
This is Marcia Columbro, and I found that much more helpful to have that there, because otherwise you were really didn't at a loss of what you were supposed to check off. So I think that was appropriate to add that.
Mm-hmm. Okay. The next ones are on PMP Counseling, specifically at your nutrition and physical activity, with the use of an intake form or notation of reviewing age-specific dietary or activity habits, discussing age-specific anticipatory guidance, and then giving a PMP handout. And these 2 measures, again, have steadily improved and look really nice in terms of the trending that has occurred over the past couple cycles, moving towards that 95% goal, with 75% of the time having appropriate documentation for our nutrition counseling, and about 67% of the time having documentation for our physical activity counseling. And then after having had some more in-depth discussions about motivational interviewing and how we can utilize that on a previous hot topic call, there was a nice good jump on this last cycle 6 of 71% of charts having appropriate documentation, looking at how ready the family is, and noting any outcomes of discussion with those families where it's applicable to use this skill set. So we're almost at that goal, and as we get closer with Cycle 7 and more people completing that data, I'm very confident that that will be achieved. And then the goal setting component, very similarly, this has always been a challenging set of measures, whether it's in WIC or our live learning collaborative. So seeing the movement with the goal setting component and especially the goal follow-up, I think that's a really hard measure to improve upon, making sure that we're always looking at previous well child visits, if there was any goals to follow up and noting progress. While we're not at that 50% mark for goal follow-up, being at a third of the time doing that is a major improvement, not only for this collaborative, for this quality improvement project, but for other initiatives that we've been working on. So I think the work that you guys have been doing here, and I have a slide on the next, is what changes have you made that have really resulted in that improvement of embedding this into your documentation to use your motivational interviewing skills, note using that, or the discussion that you've had with families when setting goals. If there have been any barriers to this so that we can continually improving this, just having those out in the open. And how do you feel that this has really impacted the care of your patients, kind of having more of these discussions within your well child visits? If there's anyone that wants to chime in before we have our next presenters come up and talk about our community resources. Well, if you guys do think of anything, we're always happy to hear about what's working for you. We can share those with others. That's maybe something that's applicable to their clinical setting or the patients that they work with. And of course, if you do have any barriers, sharing those with us as well so that we can help you troubleshoot those and be as successful as you can in this project. So I will pass over to Renee for this final slide and then for our transition into our community resources.
Great, thank you. So as you can see here, we are entering into the last module of our KETA syllabus as it's currently written. It is completely understandable and acceptable if you are maybe at the 6th module or you're at the 5th. We will get you to this point. But if you are here now, congratulations, you are well on your way to wrapping up your KETA cycle. This final module consists of the last webinar, the sustainability of PMP in your practice. You'll enter your 7th and final cycle of data, and then the final component is to do the post-project survey. And do note that this is where then we'll kind of go off of the KETA platform, and I'll work with you one-on-one to ensure that you get your MOC points and that you get the PMP resources like the MyPlates or the placemats that you can then utilize within your practice. And so there's just a little bit more to go. If you have missed a webinar along the way, this will also be the time which I'll notify you. That way you can go back through the KETA modules and watch or wrap up any loose ends. So congratulations on your accomplishments thus far. And as Samantha noted, there have been a lot of really great notes of progress over the last couple of weeks. Okay, and with that, we will welcome our first presenter. Shannon Amos is the Senior Director of Agency Programs for the Children's Hunger Alliance, and will describe to you some of their programs. To all presenters, if you have trouble moving your slides, just say next slide and I will do it for you. Thank you. Shannon?
Thank you. Thank you for inviting us to be a part of this presentation today in addressing childhood hunger in Ohio. I'm going to move through quickly, just given the time frame available, to talk about how our agency addresses childhood hunger. So we are a statewide organization, and our mission is really to purposefully ensure kids without access receive healthy food, nutrition, education, and physical activity. Our main office is here in Columbus, but we do have regional offices throughout the state of Ohio. Some of you may be aware of childhood hunger statistics, but I'm going to briefly touch on those for those of you who are not as familiar. Approximately 1 in 5 children in Ohio are impacted by food insecurity, which translates to about 600,000 kids living in food insecure households. Unfortunately, Ohio is fairly high in ranking for childhood food insecurity at 15th in the nation, so we'd like to see that go down. Our definition of food insecurity is really not knowing where your next meal is coming from or being forced to skip meals or eat less due to lack of resources. And we are probably familiar with the ways in which hunger does affect children developmentally, including cognitive, emotional, and physical delays. The inability to concentrate really in schools is a large issue, as well as we know children who are food insecure also are more likely to be absent or tardy, more trips to the school nurse. So a lot of impactful ways that food insecurity affects children in terms of just schoolwork and ability to be productive in the school environment. And then depending on the level of food insecurity, there could be a failure to learn or thrive. So I'm going to touch on the hunger relief models in terms of how we fit into the picture, because I know SNAP and WIC are going to be presented later. I really look at the hunger relief system as a three-legged stool, with SNAP and WIC being one of those legs, the emergency food banks or food pantries being another leg, and then the USDA child nutrition being the third, and that's really where our focus is. We are hoping to prevent families from getting to the point of emergency food by being able to supplement them through SNAP and WIC, and then also for children especially to provide food access through these child nutrition programs. In the state of Ohio, these are administered through the Ohio Department of Education, and of the list here, I'll talk more about all of those, with the exception of the school lunch program. That really is a program that is well utilized in Ohio right now and is pretty prevalent in all school systems. For the most part, children have access to that program. So the main emphasis of our work is the sponsorship of the Child and Adult Care Food Program, which is, again, a USDA child nutrition program, providing access for low-income kids to receive healthy and nutritious meals. And we do that in a variety of ways. Through our after-school sponsorship, we provide meals and snacks to 260-plus programs in mostly urban areas across the state of Ohio. To be eligible, an after-school program must serve kids where 50% or more of the children qualify to receive free or reduced price meals. So we're really reaching that high need population. And the way that we do that, the financial and administrative portions of those programs are really covered by us. We take care of ordering, delivering daily hot, cold, or shelf-stable, ready-to-serve meals and snacks via food vendors. So we don't produce anything ourselves, but we coordinate with food vendors across the state to do that daily delivery for us. And you can see in a couple of those pictures the unitization of those meals and how we provide those. They're ready to serve, so allows after-school programs to really focus on just providing the food and moving on with the importance of the after-school activities that they're actually there for. For family child care providers, these are mostly women who are providing care in their homes. We service about 800 of these providers, sponsor them so that they can serve healthy meals in their homes and be reimbursed for those meals from USDA dollars. So we help train them on shopping for better quality food and preparing healthy meals and snacks, helping them build menus that meet USDA child nutrition pattern standards. And then I think an area that kind of goes unnoticed is the reimbursement provided. So both for family child care providers and also for daycare centers, which we're continuing to grow. Most of these are small, we consider small businesses. There are a lot of our women and minority-owned businesses, and so being able to offset their food costs really allows them to put that money into another area, such as expanding their business or growing or providing higher quality food. And so through CACFP, we were able to provide over 7 million meals and snacks in 2017. School breakfast and summer nutrition programs, only about 56% of children who are eligible for free and reduced price lunches also participate in breakfast and only 10% access summer meal programs. So there's definitely a ways to go in terms of providing food access through these two programs. We are not a sponsor of these programs because these are mostly programs that happen in schools. For summer, those can happen in recreation centers and other locations as well. But our role in that is to advocate and consult with schools or other institutions to increase and expand access to these meals and snacks. So we help them identify and overcome barriers, whether that's something like the buses arrive late or we need to establish breakfast in the classroom to get kids kind of started with their day the right way. So we provide suggestions and best practices based on the individual program needs. A rural school system is very different than an urban school system. The size, like I said, their bus routes, their cafeteria availability, all of those things matter in terms of being able to kind of optimize school breakfast participation. And at times we're able to provide mini grants or connections to other funding for these schools. And we do a lot of lobbying and advocacy efforts to expand participation statewide. And that's not only for school breakfast and summer nutrition, but really for all child nutrition programs, including CACFP. And finally, nutrition, education, and physical activity is a focus of ours. We provide evidence-based curriculum that's taught in daycare centers, after-school programs, and summer programs. And we also help to train the child care providers themselves. So for some of our in-home child care providers, we are using the Ohio Department of Health, Ohio Healthy Programs to help them create healthier environments for the kids in the care. So that's just a very quick summary of our work, and I think I almost used my time, so I will turn it back over to Renee.
Thank you so much, Shannon. If you do have a question you'd like to specifically ask to the Children's Hunger Alliance, we ask that you put it in the chat box, and then we can revisit that as we have each presenter present. But we do want to reserve time for each of our wonderful partners here. So please do put any questions. You can direct it to me, the presenter, or you're welcome to broadcast it to all, which is completely acceptable as well. And so with that, thank you very much, Shannon, for that information. And we now welcome Benjamin Anderson. He is the Chief of the Bureau of Cash and Food Assistance Policy and Technical Assistance with the Ohio Department of Job and Family Services. Ben?
Good afternoon, and thank you for having me come and speak about the SNAP program in Ohio. Just to give you a little bit of background, the Ohio Department of Job and Family Services supervises the actual eligibility determinations that are made by the 88 county departments of Job and Family Services. So every county has one, and those are the folks who determine eligibility for SNAP. Some idea about the number of folks on SNAP in January of 2018. About 703,000 families, or 1.4 million people, receive SNAP benefits in Ohio. That's about $247 a family. So benefits are based on the size of the family, and those numbers are about, we've kind of plateaued in our caseloads. January of 2017, 747,000 families, and 1.5 million people. So caseloads are pretty steady right now in Ohio. Moving to the next slide here. What is SNAP? It's, again, the Supplemental Nutrition Assistance Program. Lots of people refer to it as food assistance, which was meant to be a softer term than food stamps. But food stamps is still pretty regularly how folks will refer to the program. Obviously, the intent is to provide nutrition assistance to low-income families. I think the focus for us is that it is a supplemental benefit. It's certainly not intended to be the primary source of funding for food. That said, it is for many families. And we don't have, or I don't have handy real good statistics on the number of households who have employed folks in them, but I believe it's far more than half of people receiving SNAP are working. In terms of who's eligible for SNAP, for the most part, about anybody's eligible. The way it works is that if you purchase and prepare your meals together with a group of people, then you're all required to be part of what, a SNAP household, and that's what the county determines eligibility based on. So the test there really is whether or not folks purchase and prepare together. Newborn can be added just as soon as they're born. They can be added to the household and realize an increase in the benefits. But we don't have sort of child-only cases, so the child would be purchasing and preparing with parents or with whomever they're living with, and that's how that would work. Low-income families, for the most part in SNAP, that's folks who are at or below 130% of poverty levels. And the next slide will show you what that kind of looks like. But there are, there are some deductions from income for shelter costs and for dependent care costs in some circumstances. So it's a fairly easy calculation to make, and there are tools out there to help you know if you're eligible or if a family might be eligible for SNAP. As you can see on this slide, looking at the bottom row, a family of four, if they're making less than $2,665 a month, could be eligible for up to the maximum allotment there of $640. So again, it's a supplemental benefit, $640. It's probably not going to meet all the nutritional needs of a family of four. How can a family apply for SNAP? There's a website here, and we're transitioning to a new eligibility system and a new website, but that one is comprehensive and directs you where you need to go. There are paper applications available at the County Department of Job and Family Services. We're slowly moving to be able to accept applications over the telephone as well. The important thing to keep in mind there is that applications have to be acted upon within 30 days. In some cases, it's 24 hours. In some cases, it's 7 days. But for the most part, the state does a really good job of acting timely on applications.
So
that's something that
WIC is for
U.S.
women
Department of
and SNAP
Agriculture
is
is
for
very
families,
focused
right?
on for all states. We
I
do
should
pretty
know
well at that.
Yeah, so WIC is for,
Here in
you have
Ohio.
to be postpartum.
The kind of food
or
SNAP
pregnant.
purchase, you hear a lot on the news about what, the lobster every election season. But you can buy baby formula with it. It's intended to buy most
No
food
booze?
products, things that are prohibited,
The hell?
alcoholic beverages, tobacco, vitamins. You see the list there. And pretty much you can use the EBT card, which is, an electronic benefit card like a credit card, where the benefits go, and grocery stores, convenience stores, any place that accepts it will have a sign in the window. And the last thing is, it's a question that we get quite often, that the work requirement maybe is a barrier to folks getting or applying for SNAP. It's true there is a work requirement, but it's very few of the number of people who actually receive the benefit are required to work. Most of them are working or are exempt from the work requirement. For you folks, a parent who's responsible for care of a child under age 6 would be exempt from the work requirement. That's all I have, and I just hit my time, so I appreciate it. If you have any questions, I'd be glad to answer them.
Thanks, Ben. We had a couple folks join, and we are very excited you were able to join. We know it's hard to squeeze this in during lunch hour. We are running through our presenters for our community partners, and if you have any questions, we have some time toward the end, so please just put them in the chat box. And with that, we'll move on to Rebecca Asmo. She's the Chief Executive Officer of the Boys and Girls Club of Greater Columbus. Thanks. Rebecca, I think I'm going to move your slides if that's okay. It's not promoting.
Yeah, thanks, Renee. If you could go to the next slide, that'd be great. So thanks for having me today. I'm really here. I'm the CEO of the clubs in the Central Ohio area, but I'm also a board member of the Ohio Alliance of Boys and Girls Clubs. And so I want to really speak to how Boys and Girls Clubs can be partners for healthcare professionals when it comes to improving health outcomes for at-risk youth. Next slide, please. Next slide. Oh, thanks. There we go. So just a quick overview of what Boys and Girls Clubs do. We are a national network of after-school providers, and we serve every single year 4 million young people between the ages of 6 and 18. In Ohio specifically, we serve about 45,000 youth each year. We have 65 club locations. 68% of the youth that we serve qualify for free and reduced school lunch, although in urban areas like Columbus, Cleveland, Toledo, Cincinnati, that number is about 98%. We serve 500,000 healthy meals and snacks annually, and our average annual fee for youth to participate is just $15. We're located in really high-need areas, and so we know that we need to keep the participation costs low. Our clubs are open from 3 to 8 p.m. Monday through Friday during the school year with some weekend hours, and then all day during the summer. So a young person can actually spend more time in a Boys and Girls Club program than they can in their school over the course of a year. So we really are a great resource for kids, but also for parents as they try to navigate that time between school and home. So we focus on at the clubs really 3 outcome areas. We want to see kids be successful in academics. We want to see them be engaged citizens with strong character, and then we want them to have a healthy lifestyle. And so in this presentation, I'll dig into a couple of those numbers. But just a quick highlight, next slide. So 92% of Boys and Girls Club alumni graduate from high school, and that's compared to just about 79% nationwide. And 34% of our African American male club alumni obtain a 4-year college degree, and that is compared to just 8% for the population. Next slide. And 57% of our club alumni actually tell us that the Boys and Girls Club saved their life, that they wouldn't be here today without the clubs. Next slide. So just to dig in a little bit to our health outcomes, we really look at 3 areas when it comes to healthy lifestyles. So we want our kids to adopt a healthy diet. We want them to make a lifelong commitment to fitness, and we want them to practice healthy lifestyle choices. And we really track these outcomes using a survey called the National Youth Outcomes Initiative Survey, but we also collect from teens specifically. Each year we administer the CDC's YRBS survey, and so we have some comparative data about our kids when we look at that survey. So just a couple of some highlights. When we look at 13 to 15-year-olds, kids engaged in the Boys and Girls Club are 40% less likely to consume alcohol, 31% less likely to participate in a physical fight, and 30% less likely to smoke marijuana. The slide here just gives an example of, nationally some of this data. When we look in Ohio, though, we actually see that 57% of our club members are physically active 5 or more days a week. We also see when it comes to healthy eating, 42% of our club members in Ohio report that they're eating 3 or more servings of vegetables a day, and 72% of our club members are reporting that they're eating 2 or more servings of fruit a day. Next slide. So here is some data just about this is some of our YRBS survey comparison data. But we really see that, when kids stay engaged in a Boys and Girls Club throughout their middle and high school years, they're really much more likely to avoid risky behaviors. I think oftentimes after school care, in families or in the community is thought of only as a need for elementary school age kids. So as you're talking to families and looking at options just to improve overall health and wellness, engagement and high quality out of school time programming is really key. And I mean, you can see by the time a Boys and Girls Club member is in 12th grade, 84% of them, and this is nationwide, are abstaining from alcohol use. And that's compared to just 58% of youth in the population. Next slide. So just a couple ways to get engaged, and certainly I have a lot more information that I'd be happy to share with the group afterwards. But if you wanted to refer patients or refer somebody in the community to a Boys and Girls Club, you can go to greatfutures.org to find the closest one in your area. We also do, here in the Central Ohio area, we have a great partnership with Nationwide Children's Hospital, and we have actually had some opportunities to train residents and to work with physicians and other healthcare professionals in our clubs. And so if you're interested in a training opportunity, you can contact our Chief Strategy Officer, Doug Wolf, to learn more about that. And then I always encourage physicians to consider volunteering volunteering in a Boys and Girls Club. Our professional staff are there every single day, but our kids really benefit when they can meet new folks. And I think once somebody gets engaged in a club, they really may think of some creative ways to really connect the bridges between the healthcare community and what's happening inside of our Boys and Girls Clubs. Next slide. Although I think that's pretty much it for my presentation.
Okay.
Thanks, Renee.
Yeah, sure. Thank you so much, Rebecca. We will be posting this webinar online, so if you didn't have a chance to write down an email or find the information, you can visit the webinar again, but you're always welcome to contact me, and I can put you in touch with anybody in our presenting team today. And with that, I'll pass it over. We're beginning our Ohio Department of Health portion. To first, we'll start with the WIC program, and we have Allison Murphy with us today. She is a registered and licensed dietitian and currently serves as the Nutrition and Administrative Services Supervisor with Ohio WIC. Allison?
Thanks, Renee. Okay, I just want to go over a real brief history that WIC was established in 1972 by an act of Congress. The first clinic opened in Pineville, Kentucky, with the first clinic in Ohio opening later in January of 1974. By 1984, Geauga County was the last county to come on board. We now have 74 projects in Ohio, but with clinics in all 88 counties. Currently, we have about 200 children, WIC, because that's a mouthful to say the whole name. We are a preventive nutrition program, and we provide nutrition education and counseling, breastfeeding education and support, supplemental foods, and referral services. Those are our primary functions. We serve women who are pregnant, who are breastfeeding, or who have an infant under 6 months of age, infants from birth until 12 months of age, and children from age 1 to 5. They will age out of our program at the end of the month of their 5th birthday. Our eligibility requirements require income. We go to 185% of the the federal poverty guidelines, or if they have adjunctive eligibility, and that would be if they have a food stamp or the SNAP card, Medicaid, and there's a few other pieces that fall into that. So they could actually be over income, but if they have Medicaid, they would still be able to be eligible for WIC. They have to live in the state in which they're applying for benefits, but they don't necessarily have to live in the same county that they're applying for benefits. So, sometimes some of our cities around here in our small towns sit on the border, and it might be easier to get to one county rather than the other. So they can go wherever they want in the state, but they have to be in the states they live in. And also then they have to have a medical or nutrition risk that's determined by a health professional in the clinic. Our investment with the program, we basically help with prenatal care, which has been shown to help decrease the prematurity rates of infants that are on our program. We have decreased the low birth weight and very low birth weight of those kiddos.
That's crazy.
Essentially, we've helped with healthcare needs by getting them referred to physicians or other groups that they might need. And essentially, for every dollar spent on WIC, it shows to be a $2 to $4 savings in Medicaid costs. We also have helped to reduce the amount of abuse and neglect that's just with children of those ages that we serve. And we basically, overall, the WIC infants tend to be in better health than eligible infants not participating on WIC. The state WIC office basically has the oversight of the program. We have several different areas within the program. The executive office, which is actually the administrative part, the vendor, which is our grocery store area, and getting the grocery stores on board where the benefits can be spent. program analysis, which is pretty self-explanatory. Development and data technology, where we develop our systems and the things we use to track everything. The Nutrition Administrative Services unit, which is my unit, which is basically the oversight of the clinic operations, making sure that we're in compliance with both federal and state guidelines. Compliance that deals with any abuse that might occur either by vendors or by participants, and also the Farmers Market Program.
And then we'll really capitalize on
This is just a basic view of what goes on at the local level with certification of our participants, the food issuance, there's a financial piece, the vendors, they maintain vendor relationships with their local grocery stores, the systems administration and nutrition education. I'm going through these really fast. The clinic staff composes of a director who oversees the program at the local level, health professionals, which in our case are registered dietitians, diet technicians that are registered with the Academy of Nutrition and Dietetics, could be four-year nutrition degrees, or they could be registered nurses. Our breakdown is about 75% of our health professionals are some sort of nutrition degreed personnel. The other 25% are registered nurses. We have a breastfeeding coordinator in each clinic. There are support staff, which does a lot of the clinical things, and breastfeeding peer helpers, which are folks that are former WIC participants, current WIC participants who have successfully breastfed their infants. And so they can help the other moms who are on the WIC program with any breastfeeding issues that they may encompass or incur. Our certification process includes intake, where we check the eligibility pieces of it, lab, where we do height, weight, and hemoglobins, counseling for nutrition and breastfeeding, and also then our benefit and card issuance. Our benefits, the foods that we provide are iron fortified formulas, commercially prepared infant fruits and vegetables and meat, infant cereal, milk, and yes, WIC does require that after the age of 2 it be 1% or skim milk that we offer. Whole grain cereals, whole grains, canned fish, primarily for breastfeeding women, canned and dried beans and peanut butter, cheese, juice, and eggs. We also have a lot of collaboratory opportunities with advisory councils, program referrals, local events. One of the things that when I was at the local level, I was hospital-based, and about once a year I would give presentations to the peds section at the hospital, to the OB section, and also to family practice. So within your communities, if you have a gathering like that, I would strongly encourage you to be in touch with your local WIC clinic and ask them to give a presentation of what's going on in their area, in your area with WIC. And with that, I gave you a really, really quick summation of what WIC is about. So if you have any questions, please feel free to contact me.
Great, thanks so much, Allison. And we'll pass it right along to our next presenter. Amy Luger is a home visiting program consultant with the Home Visitors Program. Just a note for our KETA group, we are working closely with the Home Visitor Program this year to do trainings on parenting at mealtime and playtime. So it's a very exciting collaboration, and excited for you to hear more about it. Amy?
Hi, good afternoon, everyone. Thanks again for including us today.
I recognize her voice. I had to have been on a call.
She indicated we are have our whole team across the state of home visitors that have had the opportunity to go through the training, and they are using that as a supplement to the curriculum that they use with their families. So I'll go through here to the next slide. So what is home visiting? It's in person. It's an evidence-based service that we provide to pregnant women and families, particularly those that are at risk.
Food insecurity
necessary resources and skills to help raise children.
So sore.
So we have
That's sad that barfing is an ab workout.
Including me, which I'll touch on in one of the slides here shortly, that do not currently have a provider, but home visitors are assigned to families, and they're going in and
every time I laugh or like breathe in, it's like
with those families.
it hurts.
The promise of home visiting in Ohio we're really focusing on improving the health care and access for mothers, children, and families. We are implementing family depression screenings, so both prenatally and postnatally with mom and other caregivers in the household, and then making referrals for support to the family indicated. Monitoring child safety risks for child abuse and neglect, providing parent support and education, and providing outreach to families with those linkages needed to the community. So a lot of our families were getting connected to WIC if they're not already connected, as well as the things like the SNAP program. We're also increasing child development screenings and referrals. So we're once the children are born, we are using developmental screening tools to monitor their development as they progress.
You mean like an association for food security?
Where just a quick note on why home visiting is important. Its impact on birth outcomes. Pregnant mothers who participated in home visiting had 48% fewer low-weight babies, and low birth weights lead to increased health issues and health care, as you know. Child abuse and neglect families that participated in home visiting services were 50% less likely to be involved with Child Protective Services, and also school readiness and achievement. So participating children scored about 25% higher on first through third grade reading and math achievement tests. Additionally, we're helping families become self-sufficient, addressing public safety by age 15 firstborn children who received home visits. NC were 48% less likely to be arrested than their peers. And again, the return on investment. One high-quality home visiting program over time saves taxpayers up to $5.70 for every dollar invested.
And old Christy would have to help you breastfeed.
Should be a wet nurse.
So this is just a quick slide here of the mission of Help Me Grow, again, to support pregnant women and families, and just a quick screenshot of
I like their logo.
the state-funded and the federally funded programs. And then there at the note at the bottom indicates currently where the home visiting program is not available. So that's included in Delaware, Champaign, Logan, Preble, Ottawa, Seneca, and Van Wert counties. But we are working diligently with potential providers to get there as well. Just a quick view of our comprehensive system framework and how all of these things tie together to improve maternal health. And at that, all of the pieces working together really demonstrate the successful home visiting program. Again, Ohio's home visiting system. Some assumptions that the first 1,000 days of life set the stage for fulfilling individual potential. All parents can benefit from support around the time of the birth and during the early year. And a safe, connected home is most influential learning environment. Quickly do want to make sure I get through all of these and touch on eligibility. Here's a slide on our system principles. We do implement evidence-based practices. We are strongly focused and have been working really hard over the last 2 years to implement continuous quality improvement here at the state level and across the state with all our local implementing agencies. It's relationship-based and family-centered. We strive to ensure that our home visitors receive training and that all services are culturally appropriate. Collaborations that foster collective impact and approaches that help a family to build their protective factors.
Just come back.
And just our goals here. And what is involved in a home visit? So every participant is going to receive family-driven health and wellness assessments and screenings, research-informed parenting education curriculum,
Thank you.
referrals and linkages to needed support, both medical and social, and to help facilitate transition when they are aging out of the Help Me Grow home visiting program at the age of 3 to ensure that they're going to another program. Just some of the assessments and screenings that we are implementing across the state. The ACEs is going to be a new screening that's going to be started to be conducted with families in July. We are implementing and using the Ages and Stages questionnaire in both the developmental and the social-emotional tool. The Edinburgh postnatal depression scale, an environmental safety checklist, the home observation, which is a parent-child interaction
I can
tool,
give them a book on human
the
centered design.
relationship assessment tool, which is a domestic violence tool that can be used on multiple
Thinking
caregivers
about
in the
that,
home,
like, or you
and then
could
the
have said,
safe sleep assessment
wow,
tool,
how innovative the chapter
or
is that
using it both
they're already doing
prenatally and
something that I'm
postnatally to
reading about in
ensure
a book.
families have safe sleeping environments for
Oh,
their
no.
child.
No credit.
You should really use it.
Yeah.
Just a little bit about service delivery. A single home visitor is assigned to the family. Everything's voluntary and confidential, and they take place in everyday environments. So we like to be able to provide services in the home, but if there's a need, they can meet outside the home as well. Just a quick note here about what eligibility looks like for home visiting in the state of Ohio. All families do have to be at or below 200% of the federal poverty level, and then just include one of the risk factors listed here. So the risk factors we look at just are those that indicate that a family would be at a higher risk and need these additional services. Just to touch on quickly, to make sure everybody has information how to provide or make a referral for a family. Anybody can make a referral to get a family connected to services. We do have a statewide system, central intake system. So it's a single point of entry for anybody that's interested in home visiting across the state. We have a data system that we use that will eliminate any potential for duplication of services because it is a single entry point. In order to make a referral, you can go to the refer.ohiocentralintake.org, or to be able to get information on either email or fax referrals, you can go to the helpmegrow.ohio.gov website. And then we also have some videos that are a great resource to check into, both on YouTube, and we do have social media access. And I apologize that I did go through this very quickly in the short amount of time that I had, but if you do have questions, my contact information is there.
Thanks, Amy. If you do have questions, we can now open up for all questions for our panel. And so we've had the Children's Hunger Alliance, the SNAP program, Boys and Girls Club, WIC, and the Home Visitors Program. So if you have any questions for any of them or for all of them, let's hear them. This question is for any of our panelists. How could we help encourage families to access the programs in our visits?
Hi, this is Rebecca from Boys and Girls Clubs. I think it's in terms of out-of-school time programming, and I know that this is a space where Children's Hunger Alliance serves also, but just asking them the question, you know, if they have school-age kids, are they engaged in something after school? You know, what is it? And then suggesting a resource, or talking to them about their early childhood provider, you know, and asking what kinds of meals are served there, and you know, just I think it's really just asking questions.
Okay, any other presenters want to add to that?
I would just add that this has been from the SNAP program, that directing folks to the County Department of Job and Family Services is a great idea, because the CDJFS also, in addition to SNAP, administers the Ohio Works First program, which is a cash assistance program for families with children. They also administer Medicaid, as well as publicly funded child care. So, you know, most health and human services programs are still administered at the county level through the CDJFS, and it's a great place to go to access those resources.
Great, thanks, Ben. And if you haven't had the chance to watch our food security specific webinar that featured Dr. Robert Murray, Dr. Murray talked about the 2 screening questions that are have been found to be helpful in identifying families that may be experiencing food insecurity. And so for those, definitely check out that webinar if you're interested in ideas of how you could address that food security component. And then I think Rebecca's point related to maybe the after-school programs or programs that are not as specific to food security, but like the home visitors program where there may be other risk factors involved. Other questions would be fitting. Do we have any questions for Samantha and I related to KETA for our panelists? Okay, hearing none, please do let me know if you have any follow-up needs from me. I'm happy to help as we wrap up our final KETA component. As we wrap up the webinars, we will be posting this one as we have our other ones onto the KETA platform. If you're interested, I will be working with our presenters to make sure that we can send them out to you. I know there's some helpful resources on here, and so we'll double check to make sure that they are able to go out before doing so. And with that, a huge thank you to all of our presenters today for joining us. I know with our hour time here, it was a rapid fire information sharing, but we really do appreciate you joining the call and being able to share your programs that help kids across the state of Ohio. So major thanks to you. Also thank you to Sam for presenting on KETA and to our ODH partners who are our collaborators in parenting at mealtime and playtime. With that, we're about to the 1 o'clock hour, and so thank you so very much for joining today, and I will follow up with all of you electronically. Thank you so much.
Thank you.
And Joe?